Great. Thank you so much.
Of course.
And then, yep, looks like the screen share is good.
And let me get Tony. I have an issue with him.
Just sent it, Karen.
All right, thank you. I'll get it out to everybody.
Can everybody see this?
Yes, we can see. You guys see the screen from Grant?
Great.
Got it.
Yes.
And so when I move it forward, can you see it change?
Yes.
Yes.
Great.
Yes.
Okay, perfect.
So I guess I'm gonna mute myself.
Where is she? So I sent you another link. Okay, Ron, I got your information. I have to send out a form to everybody.
All right, send it. I'll fill it out and send that back to Steve.
I will. Yes. Okay, so I got people. Can I still come in?
You're already in.
I'm in, but it's other people.
Oh,
So we'll give them a few minutes. Oh, it's 11:01. So here we go. I know there's 2 people trying to get in right now. Oh, the electronic world, right, guys?
Mm-hmm.
Okay. Here comes Tony. You got it. All right, good. All right. So as people are joining in, I'm very grateful that you've had an opportunity to join us here. I'm in my KT office down in Clark. We just moved from the 3rd floor to the 1st floor. So lots of changes going on. And in this changing world of what how benefits are being delivered, we're seeing an influx, especially in our small group market, of carriers introducing level funded, self-funded programs. You know, a year ago, there was Horizon saying, no way, we're going to bankrupt the industry, you know, and we were in a fight to maintain NatGen and AFA, Aetna's AFA program. And since then, they've taken a turnabout and they've introduced, as of January 1st, their level funded, they're calling it Horizon Select product. So we're trying to differentiate between our small group carriers, let alone the large, and Grant, I'm going to introduce him in a second, is from a large group carrier, of what to do as a broker. We've been in a world of spreadsheet rating and age band rating and doing all kinds of things that are a little bit confusing, you know, in compliance with AFA and you know, ACA and all of the rules that go along with it. And all we have really seen is a turn of events of increases after increases, and the employers are just at their wits' end as to what to do. It's very confusing. So along the way during COVID, Paul and Bob and myself joined a team down here in Clark. So we're all working together on new business opportunities. And we took a whole lot of calls from vendors that we normally wouldn't have time to do. And we met Grant, and we met his organization as an option for the larger producers. But in that, we did a little bit of training and understanding of how to present self-funded, level-funded programs to your employer groups, introduce the topics. So we thought it would be a great idea to show any of our brokers how to go about doing that for your clients, even having the topics. So hopefully by the end of tomorrow in our 2-part CE, you'll have a little bit of more confidence to at least introduce us to introduce them with you. Have a little bit of understanding as to what's going on. So they are bringing it down to the small group market. As many of you know, I'm a huge fan of level funded, self-funded programs. I really think it gives the employer an opportunity to control costs because it is the only area that they have any control is claims. So with that introduction, I'm just going to let Steve talk. He's from our CE school. He sent me some information that I'll get out to you, and you can scan it back to me by the end of tomorrow, and we'll make sure you have your CE credits. So is there anything you want to add, Steve?
No, just that my fax number and the email address are on the form, so that if they send it to me by the end of the meeting tomorrow, we'll be able to process it and give them the credits.
Okay, terrific. I'll get those out to all of you in a little bit. If you have any questions, of course, you know where to find me. And our agenda, I kind of outlined in the CE class, the introduction to the class, and I'll let Grant go through that. Because it's a CE, we are going to have a few breaks, and I know he's got some quizzes lined up for us. So in order to get your credits, you got to stay to at least answer the questions. So with that, hey, Paul, is there anything you wanted to say? Are you going to be visible here so we can see you? Okay, so Paul and Bob, they're both on the call. We're down here in the Clark office, so we're going to turn our CE meeting over to Grant, and I'll let you do your thing.
Great. Thank you so much, Karen. Paul and Steve, thank you for helping us get this set up. I'm really excited to be here right now. As Karen was saying, Flume is, I'll talk more about who we are and what we do in a minute, but really why we're here is because as Karen and Paul and I were chatting and getting to know each other, it just became really clear that something is changing in the benefits space. We are in the middle of a shift. This is a space that shifts a lot. And so you really got to be on your toes if you're going to be a broker and advisor. And so it became really clear that we needed to, or that there would be value in exploring what is this change? What does it look like? What are the new opportunities that it presents? And how do you talk about it? So Flume, you can think of Flume as a third-party administrator. We are a modern third-party administrator built specifically for the next generation of health plans. And we definitely see that coming, and I'll talk about that in a little bit. But we work with brokers and advisors across the country who have clients who are asking, what's next? What else? I'm sick of BUCA. I'm sick of fully insured. I'm sick of ASO with Highmark. What more is there? Bring me something new to the table. And we're seeing groups ditching their brokers for new brokers who are bringing ideas to the table. We're seeing groups leaving the fully insured world after 25 years and going self-funding. There's a lot of value to it. And so what I'm hoping to be able to present today is kind of like it was titled here in the presentation, winners and losers in the shifting world of employee benefits. It's titled to make it maybe a little bit more interesting to read. But in general, we definitely see that change is happening. We definitely think there's going to be winners and losers, especially given some of the conversations that we have with brokers and advisors when we're kind of consulting with them. So this is a class about self-funding basics. This is all based on questions and comments that we hear all the time. It's based on a lot of misconceptions that we hear a lot. Whether this is totally brand new to you or if you've been doing this work for a while, I think there's going to be something here that everybody will learn. If we get to the end of this 2-day presentation and you have learned nothing and you already knew everything, please let's talk, because we should be doing business together. So I'll quickly introduce myself. We're going to be joined by somebody else on my team a little bit later in the call as well. So my name is Grant Parker. I'm the head of sales enablement for Flume Health. So my job is supporting and engaging with key partners like Kistler Tiffany. And I've been doing this for a couple of years now. I've also got some clients, some self-funded plans that I've helped build with advisor and broker partners. And so I've been doing this sort of real world. And then also my job is these kinds of trainings and presentations. We're going to be joined by a man named Kevin Schlotman, who is our Chief Client Officer, one of the founders of Flume Health. He's got way more decades in the space than I do. He was the president of SPBA. He's lobbied in Congress. He's a second generation benefits advisor and third-party administrator. So he comes with a lot of industry knowledge and expertise, and also a lot of opinions. And so we're going to be your presenters for today and tomorrow. The way that this is going to look is, as you've probably gathered, this is a 2-day CE credit. So we've got 2 hours today with some breaks and some quizzes, and 2 hours tomorrow. Today, we're going to focus on part 1, which is selling self-funding, positioning it and talking about it. And step 2, where we're going to dive into self-funding, specifically into the tactics that are going to be able to save money. I want to get really granular. I want you to know how to use and talk about these tactics, and then also data. So I'm going to give some demos, and we'll talk about ways that you can use data to have better, more critical conversations with prospects about how to set up these self-funded plans, or why they should be paying attention to them in the first place. And then tomorrow we will talk about stop loss, how underwriters think, details there. And then we'll just start to peel apart a couple of different self-funding arrangements, PEOs, level funding, captives, and reference-based pricing. Again, we have found that advisors and brokers that we talk to across the country have misconceptions or straight up just major questions about how all these things work. This is what we do every day. So we are here, we're here to teach you. I think that was everything. You know, again, I'm here for you. I'm here for this group. I'm not on the sales team. I don't have anything to sell. So please feel free to ask me questions. Please feel free to pause and clarify things. You're here to get things out of it. I'm here to give you those things. So please make sure that you're using this time wisely, and that you're asking questions, even if it means interrupting me. Karen, anything else to add in there, or does anybody want to ask anything before we dive in?
All I can say is if you have questions along the way, you can put them in the chat. I'm right here watching that, and we'll make sure that Grant addresses those questions. If you have anything you want to add to the conversation, or it's not clear, please feel free to, raise your hand, and we'll make sure you get called on. This is a teaching CE, so we're hoping that you walk away with a little bit more knowledge than you came here with.
Yeah, absolutely. I'll also just go ahead and throw in the caveat. We are not here at Flume. We're not great lovers of the BUCAs. We're not great lovers of a fully insured arrangement or a BUCA ASO. And so this content is going to be very specifically focused on self-funding and why it's better than what the status quo arrangements are. I realize this is not for every group. This is not for every broker and advisor. I'm definitely not saying that everybody should be in this arrangement. There is definitely value in a fully insured arrangement, and there's definitely value that large carriers bring to the market. But especially to kind of drive certain points home, this is not going to be, we're not going to be talking about how great the BUCAs are and the carriers. We're going to be talking about what we can do to supplant them.
So just to mention to you guys that BUCA is the acronym for the mainstream carriers, Blue Cross, United, Cigna, and Aetna. So outside of those carriers, you'll hear this phrase a lot. Oh, it's a BUCA, meaning that it's one of the mainstream carriers.
Yeah, thank you. And sometimes I like to put the H on it, on the end for Humana, BUCAH, but it's like Y. It's sometimes a vowel, sometimes not.
I haven't done Humana. Okay, good point.
So I want to start us off with a quick word of advice for the group. And this actually comes from a conference that I was just at, where I was talking to advisors and brokers who are very, very focused on this kind of self-funded business. It's a group called Health Rosetta. I'll mention them a little bit later on. And I was saying that I was going to be doing this training, and I was really excited. And, she kind of grabbed me by the shirt collar, and she was like, make sure that they get a mentor. Don't try to go into this alone. This is not the world of fully insured. This is not the BUCA world. If you don't do it right, there's a lot that can go wrong for the group. You can get fired, your vendors can get fired. There's a lot of value, and this is definitely where the market is going. But my advice to you is, if this is interesting to you and what we're talking about, find yourself a mentor. I'll provide resources on how to do that towards the end of this today's presentation. But yeah, definitely try to level yourself up and find people that you can find a community you can talk to about all this. Perfect. So let's dive into the self-funding playbook. Let's start there. The thing that I think is most important to kind of lay the groundwork is that truly, regardless of what kind of company they are or what their incumbent carrier situation is, every group wants the same thing. They want to maintain plan richness, and they want to flatten the cost curve. And ideally, they'd like to be doing both of those at the same time. And I think everybody's been through these conversations where, okay, what you're asking me is impossible. But really, when we get down to it, this is the goal of the group. And a self-funded plan has a lot more levers to pull. A self-funded plan really goes from being, we're not talking about, okay, you have the off-the-shelf Blue Cross plan, you have the bronze, silver, and platinum plans. What we're talking about is, this is your plan. This is the Smith Engineering plan. This is the Gotham Greenhouses plan. And when we dial it in after a couple of years, you're going to have complete control over everything that's covered and everything that you do. And we're going to really get down to the nitty gritty of what makes your plan tick. So we're changing our mindset from buying off the shelf to building a plan that is totally this group's. And we'll talk about kind of, how to identify those things a little bit later on. But starting from the baseline, everybody wants the same thing. They want to maintain plan richness. They want to flatten the cost curve. And what we see, really, the graph on the right is based on our actual results, where we kind of looked forward a few years from our clients into what their costs would be by remaining with their incumbent. And we looked forward a few years by what they would do if they moved to self-funding. And that flat cost curve is there in a self-funded plan. The science is behind it. These plans are better for groups than being in a fully insured. The problem is just that administratively and a little bit from a mindset standpoint, it's starting to make its way down market. But Amazon, Walmart, the larger companies are already doing this. Most companies over 2,000 employees are already fully self-funded. So what we're talking about is bringing a very well-trodden playbook down market so that smaller groups can get a little more sophisticated and can benefit from those things. Generally, the groups that we're talking about, maybe 50 to 2,000 lives, their costs are on track to double every 7 to 10 years, and that's just not sustainable. Essentially, what we've been seeing in the market as Flume is that this kind of surging costs has led to a wave of what we're calling unbundling point solutions. It coincides with some regulatory changes and some transparency changes. But on average, the average health plan, regardless of who their carrier is, has 14 different vendors associated with it. And what we've seen in the market is a proliferation of independent players. So direct primary care, PBMs, value-based contracting, even networks, diabetes management. There's all these new companies that have cropped up, and they're very specific and they're very good at what they do, and they're driving results. And employers are asking, how do I get this into my health plan? And carriers are asking, how do we get those into our health plan? That's something that we do at Flume, as we work with large carriers to say, how do we integrate these pieces into your health plan? And what we are starting to see is that all of these different pieces are now starting to get integrated into what used to be legacy or a sort of status quo health plans. And so companies have the opportunity now to build their own stack of the health plan rather than just relying on the BUCAs, there's that word again, to do it for them. And we're seeing very, very high adoption rates of this. And we see that this is where the market is going, is that there's going to be health plans that customers and clients want a say in how they're structured and what's a part of it. When we look at when we look at kind of what the status quo is, we really need to understand how the current system is structured, right? So what does the world look like today? And right now it's all built on networks. The network is the carrier's main value prop. They prioritize network contracts over anything else, including sometimes, member health and steerage and guidance. They sell network contracts. Blue Cross Blue Shield does not sell health. It doesn't sell health outcomes. There's a good moniker, how much revenue do you think Blue Cross made last year on healthcare? The answer is 0. Blue Cross doesn't sell healthcare. Blue Cross sells access to healthcare. They sell their networks, and the network is their value prop. Everything else is really built on top of this: pharmacy, clinical approval, gap insurance. What the situation becomes then is that when the carrier owns the network and all of the various pieces of the stack, those pieces are meant to be checks and balances on each other. So the TPA, disease management, utilization management, they're supposed to be checks and balances. But if they're all part of the same business entity, if they are all bundled together, then everything is a profit center for that company. It actually goes against their interests. I'm using UHC here, but it could be anyone. It actually goes against their financial and business interests to lower claims spend and to lower pharmacy spend. And so if you're trying to figure out why are the costs going up year over year, one of the contributing factors to this is that the business model literally is incentivized to make the costs go up year over year. That's the only way your carrier can make more money, especially when the ACA came into play and put the 80-20 rule into play. If you have to use 80% of your revenue to pay out claims, the only way to increase your profit next year is to take in more premiums. And so what we've got is a world with pretty misaligned incentives here, and it's pretty unbalanced. And so, I'll give examples of some of the ways that we're seeing these kind of misaligned incentives playing out is in utilization review, right? So if Blue Cross or United, if they own both the PBM and the drug utilization review, then there is an opportunity to use the utilization review to steer toward a more expensive drug. Doesn't necessarily happen all the time, but when you start to dig in, you start to see that that's the opportunity, and there's business incentives for that to happen. The formulary is designed to price drugs so that people obviously choose certain drugs first. It's very, very heavily based on rebates and coupons. I think all you need to do is go on Google for 2 seconds to find out that there is a lot of misaligned incentives is a nice way of saying it. Fraud, corruption, things like that is an aggressive way of saying it. But in the pharmacy world, a lot of that is going on. The question for plan sponsors is, your formulary is written for coupons and rebates. Who's getting those coupons and rebates? It's a problem when the same company is selling you the drugs and designing the formularies that you're using. We had a client who, again, like I was mentioning, they were an auto dealership. They had been fully insured for 25 years. And I asked him, why did you leave? They came over to Flume. They were fully self-funded. And he said, it's because I learned about the PBM, and I learned that they were charging us fees and keeping rebates that had not been disclosed to me. It wasn't anywhere in the language. Nobody ever brought it up. His advisor didn't. And at that point, he just knew he had to find something different. And so in this example, an independent PBM that was built into the stack is forced to deliver their value by saving client money and keeping the costs down. We see the same things happening with utilization review and stop loss. If the same companies that's giving you your utilization review is also in charge of your gap insurance, they'll know what's coming down the pike, and there may be an incentive to delay processing or approving certain things until the contract renews in order to save money and not have to pay out. Does this happen every time? No, but there are certainly cases where this does. And the point is that the current business model that clients could find themselves in put them into a situation where there's a liability for that. Even in networks, as I was saying earlier, the carrier value is in their network. it's more valuable to them than their members. They will prioritize this asset over anything else because they don't get paid on outcomes. They get paid on fulfilling their network contracts. And so we might see members who are requiring surgery. There's a robotic surgery, which is in network. Robotic surgery to date has no safety standard or very minimal safety standards. It's still largely experimental and it's extremely expensive. And there might be the top surgeon right outside of the network where there are safety and training regulations. There's a much higher success rate and the price to the plan is much, much, much less than the robotic surgery. If a plan is built on the network and the access, then there is a misaligned incentive between getting the best possible outcome versus the outcome that's contracted in the network. And so I'm pointing these out to kind of make the point that in a standard status quo plan in the world today that we are in, there's a lot of misaligned incentives that are going on that actually put members in the middle, and it's very, very hard for clients and groups to win. And so what we're talking about here is a change in mindset, really a tectonic shift in the way that we're approaching plans. Where we're saying, how do I build the best plan that's going to make you win, rather than the plan that is easiest to get the broadest access to. And I will go ahead and pause here. Do people have questions, or does anybody want to ask anything before we move forward? Cool. And Karen, you're watching the chat, so.
Oh, yeah, I am watching the chat. But I will say one of the points that you made that was really interesting is I haven't really put together that there's 14 vendors who really produce that product, number one, and that your focus on the transparency situation where you're talking about the carrier value is in access to the network, not necessarily what they're doing to provide the services to the client. That was a really good way to put that.
Yeah, absolutely.
For misaligned incentives. I hadn't thought to word it in such a way.
Right. So, what do we do about this? How can we start to bring things to clients that are going to be designed for them to win? How do we add value here in a world that's owned by the BUCAs? And Karen, to your point, one thing that I wanted to start talking about is what makes up that healthcare stack, those 14 vendors. Who are they? How are they structured? And so this is not comprehensive. There can be a lot more, but in general, a health plan's back end is made up of a couple of pieces. One is the network. It's a big piece, but it's still just a piece. A lot of people think of the network and the health plan as one thing, but it's not. Medical management, utilization review. The third, the administration of claims processing and payments. That's just a piece of the puzzle. Every health plan right now in America has a TPA. Whether you see them or not, there's one in there somewhere. The pharmacy benefits, the stop loss, and then there is all of the ancillary, either things you might add on like chronic disease care and direct primary care, or special things that are focused on high cost drivers, or even dental, visual, things like that. So when we're trying to ask ourselves, how do we fix this problem of the misaligned incentives, the first thing you really need to be able to know is this is what the health plan is made of. Each of these pieces should be seen as, and in a self-funded plan is seen as modular. What we want to get to is having individual partners that are running each of these pieces of the plan, because then their incentives are going to be aligned with the plans. Each of these partners is chosen for the value that they can bring to the plan. It's not part of a larger whole whose goal is to be a profit center for the plan. So we'll go into a little bit more detail about how this all builds out, but what we're really looking for is building a plan out of independent partners, one piece at a time, integrating them together on the back end to make up a plan that's really designed specifically to help that employer win. So we're putting the employer at the center of this plan, rather than making the employer part of a large carrier plan. And the revenue model follows, right? The revenue model is pretty easy to look at from this perspective, which is that there's a couple of different ways to look at the numbers. And actually tomorrow we'll go a little bit deeper into them. But when you start to break apart the health plan, it looks very, very similar to a fully insured plan. So you've got fixed fees, which are all of the admin pieces for those various partners, the TPA, the PBM, the broker fees, your stop loss premium, things that remain fixed for the plan. But then you've got the variable fees. And this is a different way of thinking about plans. It's not the way a lot of employers are thinking. It's not the way a lot of advisors are thinking, but it is to us the right way of thinking, which is you got your fixed fees and then you got your variable, which is the claims that come in throughout the year. How is the plan being used? We say two things drive the cost of a plan, frequency of claims and amount of claims or severity of claims. So tomorrow we'll go a little bit deeper into breaking those things out. But suffice it to say for today, if we're talking about building a self-funded plan, the revenue model is still very, very simple. This is not rocket science. It's not something that should be shied away from because a fully insured plan is so much simpler. You got a fixed fee and you've got a variable, which is your claims amount, and that adds up to your total cost of ownership for the plan. So when approaching a client, this is how they should really be thinking about the way that their plan is designed, not, fully insured one number all the time, but really let's get down into it and start pulling this plan apart so you can understand your supply chain. So for pricing of a self-funded plan, it looks slightly different than, a fully insured, but we got our admin price, we've got the premium, which is for the stop loss. And then we've got a little bit of a variable. This is not a number that we can accurately predict at the beginning of the year. We can get very close. Underwriters are smart people. They do their jobs really well. If we knew exactly how much claims a group was going to spend in a year, we would, we'd have a crystal ball and we'd be out making a lot more money doing something else. But we can speculate and guess based on the history of the group as to how much their claims will be in a year, and that'll add up to the total cost. And so one of the things that these clients really will require is to be comfortable with not having a solid number that they're going to be paying, but it will be a little bit fluid. And when you take that risk, there's a reward. And we'll talk more about that later on in our lesson. But this is the way that we're thinking about the finances for these plans. There's a fixed fee, there's variable claims, and that adds up to the total cost of ownership. I'm going to pause a little bit between these things to kind of wait and see if anybody has questions. So again, please feel free to shout them out here. So one thing that is also very, very important to bring up, just as we start to think about building and conceptualizing these self-funded plans, is the regulatory and legal. And one of the reasons that we really felt strongly about putting this in is because a lot of advisors come to us and they say, I want to just copy paste what they've got. They've got a plan, it's with United. I just want to copy paste that and make it self-funded. And we're good to go. They want to take as little change as possible. This doesn't really work in this world for a couple of reasons. And the main one being that self-funded plans and fully insured plans have different regulatory requirements. It's not something that you as an advisor need to become an expert on. We'll talk about that in a little bit, but there are actually fewer rules for self-funded plans than there are for fully insured plans. So it's not the best idea to always just dive in and say, I want to make things one-to-one. A real key thing to do as a client is talking to you about how they want their plan to look and what they think is really important to them, is think and listen critically and try to pick out places where you think, based on your expertise, we might run into some issues. A really, really common issue that happens is accidental discrimination. This is not, the client saying, oh, well, I don't like our warehouse workers. We want to give them worse benefits. I really like our headquarter workers. But there are ways to be discriminatory totally by accident. How are the plan tiers priced differently? You could be offering a plan, but functionally not offering a plan. And that could put the plan under scrutiny, and it could make them liable to some legal scrutiny through ERISA. And so one of the things to really look at in a plan design is how is this offering being presented to the group, and is it available to everybody? Is there true equity here? And then another really, really important thing when it comes to these groups, and again, we wind up giving this advice all the time to brokers and advisors who are trying to get these plans built up. And it's something that winds up coming up late down the line when it should be very early on, is eligibility and leave policies and things like that are huge, especially when it comes to stop loss coverage and contract terms. We'll talk more about this in our piece tomorrow on self-funding, but there are really important questions that need to be asked of these self-funded groups. When you file a stop loss claim, you've got to be able to prove that the person was eligible at the time. Were they on FMLA? Had they been paying their premiums? Were they on COBRA? Even things like if long-term disability and short-term disability aren't defined clearly in the plan documents ahead of time, it won't be reimbursed for stop loss. And so the group can become liable to large claims that weren't eligible for coverage by the stop loss policy. And so, Karen, I see you raising your hand. You might be a little muted.
So we have a question. So back up a little bit. And so the question is, when you break out all the vendors that we're talking about, I know it's like a plug and play. Doesn't ease of use become an issue for that broker to manage? So when I'm sure you'll be presented this at some point about why the TPA is so important within the vendor selection. So I know you'll answer the question, but I wanted to bring it because that is a common concern with the brokers I work with. Like, oh, that's just so confusing. And my answer has always been, well, it really depends upon the TPA you're using in order to plug and play those specific vendors that we're looking for. On the flip side, if we don't have that kind of accommodation, we're not doing our best job to control costs. So on the way, I want to answer that question. So thank you.
Yeah, thank you for bringing that up. Thank you for asking the questions. I love questions. It lets me know I'm not just talking into the void.
I know they won't show themselves. So I was like, come on, guys, we're talking to names.
Oh, that's okay. That's okay.
No,
all
right.
It's a perfect question. The answer that you gave, Karen, is correct. I have it a little bit later in the presentation. I want to talk about the very key role that a third-party administrator plays. I think that's why a TPA like Flume was the right person to kind of ask to talk about this. So I definitely will come back to that, but you are right. There's a lot going on in a self-funded plan. It's important for an advisor to know in order to be able to navigate these waters, but I'm going to talk about that a little bit later on.
Brant, can you hear me?
I can hear you.
Tom DeSalvatore, quick question on the eligibility rules. So basically, when you're talking to a client about maybe shifting to this self-funded, which I have very limited knowledge of, Karen tries to teach me. Doesn't this revolve more around the HR or around the employee benefits handbook? Because now you're talking about having certain rules in place prior to your placing this account in a self-funded environment. Is that kind of correct?
Yes, I mean, any company that's offering health benefits definitely has eligibility rules. I mean, these are eligibility rules like how many days do you have to be working at the company before you can sign up for the health plan?
So we would need to know what the handbook has in its current form and be able to have them offer suggestions on modifying it, especially when it comes to the stop losses and whatever you're going to discuss, correct?
Yes, and I would make the point. I know that sounds like some extra work, but there is a lot of value that can be added to a client by coming to them. And I mean, just from personal experience, we've had groups that they haven't changed their health plan. They just keep renewing. They haven't changed their health plan in 15 years, 10 years. The rules are so different now than they were back then. And, the current broker that they're with is not really thinking critically about these kinds of things. They're kind of just managing the renewal and stepping in. And we've been brought into groups where they are actually exposed to a lot of legal liability because they haven't been updating their policies or they haven't been paying close attention to this. And we've had to kind of step in and help the broker step in and say, you know what, I started talking to you about your health benefits because I thought I could save you money. But honestly, like, I think your group is at risk for some major legal liabilities. Like, we should dig into this. And we've had brokers that have uncovered major problems that groups weren't aware of because they started asking these questions. And that's a value add that that broker has been able to bring to the table and, you know, take them away from their incumbent broker who was just kind of going through the motions.
Just to add to that a little bit for you, I just want to mention that I can't tell you the number of accounts that we've been able to at least bid on and get involved with because we have some knowledge of alternative funding mechanism. You know, that we can actually, I would say, competently say, would you like to look at another way to fund your employee benefits healthcare spend? So it really will answer that question for you, Tom.
Thank you, Karen.
Yeah.
Thanks, Greg.
Yeah, absolutely. And I will talk about the TPA's role in all of that in just a little bit, because it actually is easier on you than you think. But we have certainly seen as a tactic for opening business and for closing business, saying, you know, when was the last time you reviewed your regulatory standing? You're probably at exposure for some risk here.
This also brings me up to a point, I guess, approaching a group at this point, you're talking probably 90 to 120 days out. If you're starting from scratch with something like you just mentioned, where they were just going through the motions every year with a renewal, and now you're bringing in your expertise, correct?
Yeah, or longer. I mean, I really think
longer.
I think the value here is in playing the longer game, trying to start that conversation. Because again, it's such a mindset change for these groups and for you, but there's huge value. And if you can, you know, again, we've seen brokers where all they're getting is just renewals from their broker, and they're starting to ask like, well, what else? You know, we had a group who left Holmes Murphy, which is a huge brokerage, because, you know, the official recommendation one year was just to take the 47% increase and pass the costs on to the employee. And the employer was like, does anybody else have a better idea? Is there any other ideas out there than that? And, you know, there was a broker who came in and said, yeah, you should look at alternative funding, and here's how we do this. And it's exactly what the group was looking for. So another thing that I think is really important to kind of understand when talking to groups about making this change is, yes, it's a mind shift change. Yes, it's a difference in the way that the plan runs. But on the administrative level for the client, it's very, very the same as a BUCA plan. The administrative burden that groups can expect when they're in a self-funded plan versus a fully insured is, one, managing the claims fund. So there's a little bit of financial need. You need to set up a bank account where you can pay your claims from, and you need to keep that account funded. But any controller should be able to do this, no problem. So it's a pretty light lift. You need to be doing your monthly enrollment and eligibility, which is something you're already doing in your fully insured plan. You need to be saying once, you know, when somebody leaves, you need to be marking them as left. And when somebody joins, you need to be adding them to the plan. So you need to be doing that. And you need to be electing your coverage controls. And you can get very, very granular as a self-funded plan. You can have complete control, but you don't need to, especially not year one. So the administrative burden on running a plan like what we're going to be talking about really is pretty light. Other than having to set up one bank account, it should not look all that much different to an employer than their fully insured group until that employer is ready to get really involved in the plan design. And we'll talk about this as well. I don't know if there's an employer out there who hasn't already done something like this with their PNC policies. We'll talk about this a little bit later on as well, but most groups have gone through this process already where they started to get self-funded and really granular in how their PNC policies were set up. And we've had a lot of light bulb moments with groups where it's like, well, you know, Mr. or Mrs. CFO, you already did this. Remember when you started, when you kind of changed the way that your fleet of vans was covered and you started being more focused on risk mitigation. They're like, oh, it's the exact same thing. So there's a precedent for doing this already. It's really not that big of a lift for these groups. it shouldn't be conveyed as some major earth-shattering change. Really, it looks very, very similar to the group. And so then we come to, who are we looking for? Who are the right groups for this? I said at the beginning of this, self-funding is not for everybody. This is not a catch-all. I really don't believe that. But we are looking for the right kinds of clients, especially as we're starting out. You want to find those low-hanging fruits. You want to find the people who are philosophically aligned with this, and they'll work with you to develop this plan. So the first thing we're looking for is groups that are financially stable. That's kind of a gimme. They need to be able to keep their claims funded. They need to be able to pay their claims. If they can't do that, they probably have bigger problems anyway, but it's certainly a point number one. We're wanting to look for groups that are opinionated about their plan design. Some of them don't care. Some of them can afford 15% yearly increases, and they really don't get a lot of complaints. And in that case, this is not top of their priority list. We always say companies are good because they're really good at making shoes or at, shipping cardboard boxes. They're not supposed to be good at benefits, but some of them should be very opinionated about the plan design. And that's who we're looking for, is the groups that are trying to find what's next, what more can we do, what else can be done about this. They're the ones that are really tuned in here. And we're looking for groups that are going to be a little bit more tolerant to risk and disruption. This is obviously a change. It's going to be a change in the way that they run their business. To that end, I kind of want to be really clear. The people that we should be talking to about these plans may not be, and in some cases certainly are not, HR. HR is not a great place to try to start talking about this, because we're talking about a financial arrangement here. We're talking about a supply chain of healthcare here. HR is certainly an important part, and the member experience is very, very critical. However, I would encourage, as we're going out and prospecting and looking for new accounts, start thinking about this as a financial arrangement. Find the CFO, find the CEO, find the people who have something to say about how the business is run on an operational level. This is where we can really affect change for these groups. And then, HR should definitely be part of the conversation. If the CEO kind of pushes the conversation off and says, oh, HR picks our benefits, I think it's a great place to challenge that thinking a little bit and make some of these points that we're going to learn throughout this course and say, this truly is a financial decision. This is a supply chain decision. I think this is something that the CFO or the COO or the CEO certainly needs to be heavily involved in. The HR team, they do a great job, and they have really, really important roles to fill, but they're not typically financial thinkers. They're not typically tuned into the ways that the other pieces of the operations of the business run. And what we're talking about is taking this out of just human resources and starting to look at the financial setup, the legal setup of the plan, and making improvements there. So I really want to kind of stress, get to the CFO, get to the CEO. Don't just stop at HR. This is not really the way that those decisions tend to be made. And last, I would say the thing that we're looking for in a group, and the thing that we can offer them with plans like this, is information and control. There is a ton of details and information and data that are available in plans like this. I will use some of that today and tomorrow to kind of show those things off. We're looking for groups that are wanting information and control, because we can offer it to them when a fully insured plan, a BUCA plan, even a BUCA ASO plan really can't. So I actually want to give an example of what I'm talking about here. This is a screenshot. We're actually going to leave the presentation for just a minute. So I'm going to stop sharing, but I want to give a demo, kind of a tour. I want to show people the kind of information that we can find and expect when we build this, when we build plans like this. So this is a portal. It's called Plan Watch. Maybe you've heard of Deerwalk or any of the other things. It's a data portal. Claims data flows from the third-party administrator into this portal, and then anybody, the broker, the employer, can access this at any time. It's updated on a real-time basis. It's updated every week. And so this is not, monthly uploads and things like this. This is highly available data. And, just I kind of want to point out sort of the granularity, the level of data that becomes available on plans like these. So over here, we have data broken out by a lot of different areas. So if we wanted to see for the group, for example, oops, I was signed out there. If we wanted to see, for example, the kinds of diagnoses that our group is seeing, we don't have to wait for the BI report at the end of the year. We can see every week where we are spending the most money. This is all dummy data, so don't worry about any of that. But we can see where the money is going. We can see what kind of diagnoses our group is having. This helps us design better plan changes for next year. If we dig into, oh, we have problems with digestive system, we can actually see how these claims are breaking out by employee. We can filter it a lot of different ways. So we can view it by employee, we can view it by provider, we can view it all over the place. If we try to look at it by claims, we can see a claim level view one at a time of what we're spending all of our money in. Again, this is dummy data, so there's not a ton in there. It's obviously HIPAA compliant, and so we're not trying to give, unwarranted information to plans. But this is not the level of information that most groups are used to having about their plan. This is not the kind of thing that they're used to seeing. And so we can go in and we can look and see exactly what this $86,000 charge was, and we can find ways to start to address and mitigate that. Again, we can see it by the facilities that we're going to. We can see where we're spending the most money. We can try to come up with plans to minimize, if we're spending this much money at this facility, here's why. We can try to address that. I think I'm getting the point across. There's a lot of information that becomes available to plan sponsors when they own the data. BUGAs and carriers will tell clients that the data belongs to them, that it's Blue Cross's data. We don't think this is true at all. Clients have a legal right to access their data. It's something that's withheld from them for a number of different reasons, usually because it makes it harder for them to renew or leave groups. But what we want to do is give a lot of data to these groups. It can be exported, it can be parsed in a number of different ways. And so, one of the things that can be used in conversations with clients and prospects is, let me show you what kind of information we're actually talking about here, Mr. CFO, Mrs. CFO. You have information about every other piece of your business, except for your healthcare, which to date has been a black box. I'm trying to open that up so that you can start to have information and make decisions for the future of your company. Any questions here regarding, data delivery and
At what point would you start lasering clients? The second year?
If the data is available, you can laser them in the first year, and that's an important part of the stop loss conversation, something we'll go into more detail about tomorrow. But if the information is there, yeah, you can laser them year one. And then, yeah, like you're saying, this is really going to make it very possible to start getting very granular about where the plan is spending the money, and coming up with mitigation tactics for that.
Grant, that's a really good question, because I think there's a misunderstanding of what lasering actually means. For the most part, I'll get, well, we can't eliminate coverage on people. And I said, well, that's not exactly what lasering is going to do for you. So we'll set different levels of an aggregate amount that we're going to expect if the plan's going to pay, and then you're going to pay. They don't understand the terminology as we're re-entering underwriting our health groups now. And I think that's an important piece of information in our conversation to the clients. Is like, there's a lot of misunderstanding about self-funding, level funding, the terminology within the program. They think that it's a bad thing, that isn't going to be fruitful for their employees, that their employees are going to have exposure. So one of the intentions of doing classes like this is to alleviate that concern. That's not at all what this is about.
Yeah, completely. We're not, the idea is not to take coverage or change coverage for certain people. The idea is to build that into the plan design. Like we're aware of these things. We should be able to build around these. It's time to stop buying off the shelf, which is treating every member the same. And it's time to start understanding this is where the cost drivers in our plan are. Let's build around that. And I'm going to talk more about that later on. But you're absolutely right. It's not about removing coverage from certain things. It's about accommodating those needs for the group.
But it's just a matter of when you're going from a fully funded group to a self-funded first year, where do you get this background information that helps you determine where you're placing this client the first year?
Yeah, it's a good question. There certainly data is made available by these carriers. It's at different levels. Sometimes there's no data. The carriers refuse to give that. Again, generally that's because that's a tactic to keep groups from changing plans. We will talk about actually, I have it addressed, I think tomorrow, what to do, what levels of data you can get and what's important. If you can get historical data, and again, that becomes part of the stop loss conversation. It becomes part of the plan design. Here's what we know about this group. Here's what we need to accommodate. But again, if not, usually then yes, it's a longer term strategy. You have zero data right now, Mr. or Mrs. CEO. We need to get you into a plan design that's going to start getting you data. And your first year is just going to be all about getting data. And then once we have that data, we can start to build a better plan on top of it. But really, that's something that these employers need to know. Until you can start getting data about your plan, you cannot fix your problem.
Thank you.
Your problem is a 30% yearly increase, a 15% yearly increase. How many years will it take for you to start addressing this problem? You can't fix this problem by renewing as is. So we'll definitely talk about how and when to use data. It's built a little bit later into the presentation, Tom.
Okay.
Grant, there's another question here about PHI. And information to the employer and protecting the employee from the employer. I think the data. So would you like to address that?
Yeah, I mean, we're very, very big believers in that. We'll come across groups where they're very, very paternalistic. The head of HR or somebody, sometimes the CFO, knows everybody's medical problems and their job has been to kind of help. We don't love that scenario. It's not really our job to tell companies how to manage their people, right? But our job is definitely to make sure that the plan design is HIPAA compliant. So for example, the data that we're seeing here is divorced of employee name. The employer could not use the data that's coming into them to identify specific employees. It's something that Flume is aware of. It's something that our customer support is aware of. It's something that other vendors on the plan are aware of, but there definitely is a firewall between the employer and the client. Sometimes, and the member, sometimes the employers, want to know. Sometimes the employees go to the employers and let them know about this. Sometimes it's something the employer already knows about. I'll give a couple of case studies in a few minutes, but in general, there should be a firewall between the employer and the members to try to make sure that, they could get in trouble. If they know too much information, they're exposing themselves to legal liability. And so, your plan design needs to help with that for sure.
So Grant, to that point, is there ever a time where that information would be disclosed to the employer?
Yes, there are definite cases where the information is disclosed. One, and I'll kind of give a case study about it in just a little bit, is when there's an opportunity for like helping a patient choose a different pathway in order to receive some sort of incentive from the plan. When there's major surgeries that are coming up or major cost drivers and things like that, sometimes that's something that the employer needs to know because it becomes part of the stop loss conversation. It becomes part of the renewal conversation. There's certainly cases like that, but in general, we try to keep that firewall. Sometimes the employers just barrel right through that firewall and they try and go and find out who it is on their own. Again, we're not really in charge of what the groups do.
Well, a lot of times they find out because they're not working or there's there's some other extenuating circumstances.
Right. A lot of times the plans are very aware of what's going on. I mean, a lot of these companies, they think of themselves as families. They know what's going on in each other's lives. But you definitely want to play by the HIPAA rules, and you definitely don't want to create exposures for groups unnecessarily. So we're getting into, this is all leading up to what role we think the TPA should play. There's all kinds of TPAs out there. Again, I didn't come here to sell Flume's TPA services. In general, though, I would try to give guidelines as far as what you should be looking for in a TPA. I think questions that are really important to answer and things that a modern TPA today should be able to do. The first one is be able to provide data. Live or near real-time data, like what we were just looking at, should be table stakes at this point. If you can't get data out of a TPA, move on and find another one, because we're just can't do anything without data. Keeping the plan in regulatory good standing. So we were talking about the legal and regulatory requirements a little bit earlier. We were just talking about HIPAA. In our world, these are things that the TPA is really responsible for. Brokers and advisors should be working together with their TPA to make sure that these things are happening. There should be expertise on both sides of the aisle. It should be a partnership and a relationship, not just a faceless, business transaction. But the TPA should be coming to the table with expertise in how to build these plans and what the regulatory requirements are. They should be giving you advice, and they should be giving the client advice, and they should be watching throughout the year to make sure that the plan is keeping in regulatory good standing. That's something that I would look for in a TPA, not try to cram into your own brain. They should be creating and maintaining all of the stop loss documentation. All of the reporting should be flowing through the TPA. The TPA is the nexus of the plan data. They should be set up and built to be able to do that and do that very well. Again, if you're finding TPAs that aren't doing that or can't doing that or fail to do that, you should move on. And then the TPA should be the quarterback for the member in the plan features. We were just talking about kind of trying to keep the employer out of things. The customer success line and the TPA should be the ones that members and patients are interacting with. They should not ideally be going to their HR teams to try to find resolution for issues. One, because the HR team just isn't equipped to do that. Two, HIPAA reasons. And so, at Flume, we try very hard to get members to contact us first, call the concierge. We are here to help you. The TPA should be the quarterback between all of these different vendors. If somebody was asking about all the different vendors, we think that the TPA is the nexus of this plan. The plan should be powered by that TPA. We should be quarterbacking. The TPA should be quarterbacking the PBM and the stop loss carrier and everything. The broker should be focused on finding new business, creating relationships with their clients, talking through renewals and being strategic about what's going to happen. They shouldn't be the quarterback for PBM claim issues. Quickly, I want to talk about what can go wrong, just some things to keep heads up. Obviously, if a group is self-funded, they're paying the claims. There's a risk, there's a chance that a huge claim could come in and cripple a company that's not prepared. That's why they need to be financially stable. They need to understand what they're getting into. A lot of brokers have caused a lot of problems by bringing clients into self-funded arrangements without really doing the sale properly, without really talking through it properly, without really setting the plan up properly. And groups can wind up in trouble. Similarly, the vendors that are selected might not perform. We think that the TPA is really well positioned to bring vendors to the table that are trustworthy and that we know can perform. Advisors sometimes go and find their own as well. But if a vendor doesn't perform in a plan, it can be a problem. What should not be done is throwing the entire plan out because one piece of it's not performing. In a fully insured and in a BUCO world, that's what you have to do. Something's not working. You're not sure what it is. You got to throw the whole thing out and you got to go over to Aetna this year. What we're talking about is being able to really pinpoint the PBM is the problem. Let's get a new PBM. And again, gaps in coverage could expose the groups to liability, whether this is COBRA and FMLA related or stop loss documentation. Your TPA really should be telling you about how to set this up and really should be driving that ship for you in the group. But if it's not set up correctly, there's exposure to liability for the group. All right, we have arrived at our quiz. Karen or Steve, what is the best way to do the quiz and make sure that that people get the credits for their CEs?
I would say answer the question in the chat.
Okay, great. Okay, then I'm going to ask this question, and then everybody can answer it in the chat. This should be easy because we just kind of went over it. So here's your question. True or false? It is the broker's responsibility to maintain stop loss documentation for the plan. True or false? It's the broker's responsibility to maintain stop loss documentation for the plan. So I'll give people kind of a minute to respond. And then Karen or Steve, if you will kind of keep track of the answers that come through. That question one more time, true or false? It's the broker's responsibility to maintain stop loss documentation for the plan.
Well, it's almost 100% false answer. Everyone's responding greatly here, Grant.
Great. I mean, good. The answer is false. This is something that your TPA should be performing. As you are evaluating partners and TPAs, please make sure that this comes up in your conversations.
Really important, because if it falls back on you as the broker to make those kind of decisions, it can be really confusing.
Exactly. Awesome. Well done, everybody. I'm really glad that that information is coming through. Okay, so I want to quickly touch on expected results. What can we expect from a self-funded plan? Again, this is not new. Self-funding is not new. This has been around forever. Like I said, 80% of companies, 2,000 employees and more, are already doing this and have been for years. These companies aren't guinea pigs. They're not experiments in some newfangled type of plan design. What is happening is that plan designs that are already working very, very well for larger companies are moving down market, and people are leaving their status quo renewal cycles and doing something different. So what can we expect when a plan moves to self-funded? The first is that plans that move to self-funded will kind of operate on a pretty predictable cycle. We'll talk about the ultimate results, but first I just wanted to mention that usually the way to think about it isn't, oh my gosh, this is going to solve everything. You're still taking risk as a self-funded plan. You're paying all of the claims. So the way that we see it is 1 in 5 years, the plan is going to be totally blown out of the water. They're going to have a really, really bad year. They're going to be 25% above whatever their expected amount was. Something terrible is going to happen, and they're going to have to pay for it. And then 1 in 5 years, they're going to be 25% below what their expected claims was. And the group is just going to perform miraculously. And that chronic disease person is not going to cost any money. And they're actually going to save 25% on what they thought they were going to save. This isn't a company profit. This isn't money in the pocket of the CFO. This is the plan's asset, but they're going to be below. And then the rest of the years is going to be somewhere in the middle. They're going to be minus 5% one year. They're going to be up 5% the next year. They're going to be flat one year. But in general, the plan is going to waver, and they should be prepared for this financially. However, in terms of real world results, what we see over and over, and this is not just Flume, but this is just the standard, is that plans are going to outperform fully insured plans. Any plan that's built with risk mitigation in mind is going to outperform a plan that's not built with risk mitigation in mind. So what we see, and I used our results rather than sort of statistics, what we see is almost $500,000 savings in the first year for every 100 employees on the group for plans that switch and leave fully insured. What we're seeing is groups that are coming well underneath expected claims costs because they're building cost containment features right into the plan, which we're going to talk about in our next section that's coming up here. And in general, groups are going to beat the fully insured market anywhere from 2 to 5% on a regular yearly basis. Flume is seeing a negative 1% renewal for our groups, which means they're paying less last year than they were this year, and less this year than they were the year before. And so there's a lot of financial sense to making this change, because you can and you will beat the market when you go self-funded. The hurdle is just getting your mind right to actually do it. Quickly, I want to talk about what your mindset as a broker should be is not, hey, let's jump into this, but let's walk into this. Let's come up with a multiple year strategy for this. This makes clients much, much stickier. If they're changing their, the average contract for, or the average retention for a BUCA plan is like 18 months, something like that. If you're giving them a plan for multiple years and trying to get them to a goal, they're very much more likely to stay there. So what we're talking about is being really prescriptive about what we're going to do year 1, year 2, year 3. We're going to move just little steps every year so that this plan gets more and more dialed in to where you want it to be. This is something that, should be thought through critically. It's a strategy that you can develop. But yeah, a lot of groups are not being brought ideas like this right now. And the brokers who can bring fresh ideas to the table and an actual strategy are the ones who are going to win in this new system. So I just want to make the point.
Grant, could you just talk a little bit about this? Because this is a broker group that would be quite interested in your prescription of how you're going to move from, we have one carrier partner that calls this the crawl, walk, run approach. So what do you mean when you say year 1 will focus fixed PPO but, and then you go to flex and open access? So give a little conversation to that terminology and your thought process behind suggesting this as a possible strategy.
Gladly. So this is something that Flume has developed over the years, something that we've seen groups saying yes to. The idea of jumping from fully insured or wherever they are into something totally new is very unappetizing. It's a very heavy lift. Usually what we're seeing, and I'll talk a little bit about this in the next module, is that the network that a plan chooses, it shouldn't define the plan, but it certainly has a lot to do with how the rest of the plan gets built. So you can see here, for example, Cigna as a name brand network, most groups would not object to Cigna being on the table for them. They know they know the brand name, their employees know the brand name. It's very, very easy to digest. Fewer of them know First Health, even though First Health is a huge national network. So, but you can see if you wanted to build a plan around the Cigna network, which is easy for a group to say yes to, it comes with some limitations. You can break out the pharmacy for sure. You can do reporting and you can give a nice concierge member experience, but Cigna doesn't let you do certain things. You can't do direct contracting. You can't do chronic disease management on Cigna. You can't even audit all of the bills for fraud, waste, and abuse. And so what is this good for? This is good for not cost containment, but it's good for getting the group into their first self-funded plan. It feels like BUCA, it looks like BUCA, the back end runs slightly differently, but year 1, all I want you to do is just get into a self-funded plan so we can start getting data in the door. Your employees probably won't even notice the difference. We really can't do anything fun for cost containment, but it's going to be a step in the right direction. Once we've spent a year gathering data on this group, then we can start to look at more things we can do with plan design. And that's what module 2 is all about. So I'm introducing this here and we'll dive deeper into it in the next module. But this is going to be a slightly different network. We need one that's going to give us more flexibility. So we have to leave Cigna, but the trade-off for leaving Cigna is you're going to get a lot more freedom to address the costs of your plan elsewhere, which is going to drive savings for you. So now we can start doing direct contracting and steerage, and we have plan data so that we know exactly how to be doing that. And so once we run this plan for a few years, every year we're looking at how it's doing, we're trading in vendors in and out. Maybe there's a world in which this group wants to go into reference-based pricing. Maybe they want to do some other crazy things, like maybe that's kind of where the CEO's mind is. We can do that later on. Let's not jump there this year. Let's please walk towards the goal for the group. So it's important up front to start to understand, like, where do you want this to go? What's your mindset? What's the goals for this group? How can we get you there, not in 1 year, but how can we get you there in 3 years, 4 years, so that this isn't, a huge jump. I heard somebody say once, if you go from 0 to 60, that's not acceleration, that's a wreck. We're not trying to get this group to go from 0 to 60. We're trying to get this group to their destination in whatever way is going to be best for them. So in the next module, we're going to actually dive deeper into a lot of the different risk mitigation and cost containment tactics that we can put into plans. And this is kind of to say, if we want to do those things, there's a way to structure a multi-year approach that's going to let us do it nicely and gradually so that it's not a huge disruption to the members. Thank you for that question, Karen. Oh, you're still muted.
I know, I'm sorry. So we have questions coming in about using Cigna for our reference-based pricing, using, renting the network and all of that, probably in your Flex PPO, you'd address that. So these, I'm sure, are questions you're going to address shortly. But
Yeah.
I think we need to give them a break.
We are very, very close.
Okay. Are you almost ready for break time?
Yeah, we're going a little bit over, but we're very, very close to break time.
Okay.
Thank you. Sorry. So yeah, really quickly, I just want to review what are the value props that we've learned here today. Self-funded plans give transparency, control, savings, and they drive better health outcomes. We'll get into the details about a lot of this later, but these are your key value props and your takeaways. We've got some case studies that I will be providing that'll help kind of tell that story, and we'll come back to those. But I want to provide a summary of this, of what we've learned here, and then we'll go into a break and into module two. So summary of section 1, selling self-funding. You want to align the incentives. Independent plan design lets you align incentives with the employer rather than put the employer into a plan whose incentives are outside of their interests. You want to find the right person. You want leads who are opinionated, open to disruption, and wanting control of their plan. And you want to think long-term. Clients are stickier when there's a multi-year plan in place for them. We're going to provide some resources for everybody. We've got a one-pager that is client-facing that you can go ahead and take right now and use to find prospects. I've got a template that I'll give everybody. It's 10 qualifying questions that I think are the right questions to be asking self-funded groups. If they don't have good questions for these, if they don't have good answers for these questions, they're probably not super qualified to continue this conversation. They may be better suited for, next year. And then I mentioned mentorship at the top. I want to provide some links. There are organizations that you can use to level up your skills, grow your community, and learn more about this. Health Rosetta and Masterminds are 2 such organizations. So you'll have all of these after the lesson closes today. And with that, we are going to take a break. It says 5 minutes. I'll give maybe a little bit more, but it's 12:15. So do you want to do 5? Do we want to be back here at 12:20 or?
I would say let's give them 12:20.
All right. So everybody, please be back here at 12:20, and we will move into the next module.
Okay. I should play some music or something, Grant.
Great idea. I will do that.
Okay, we're getting back.
All right, welcome back, everybody.
I've got a lot of questions coming back and forth here, Grant, and the interest is very interesting. So as we get into the second module, I think you'll be answering most of the questions that came in over.
Yeah, absolutely. Let me let's get into kind of what the second module is about, and we'll see if the questions don't line up. All right, well, let's go ahead and get started. We're more than halfway through the time here. Thank you, everybody, by the way. Just thank you so much for your attention, for your questions. It's been great. I like talking about this, and I'm really glad to hear some of the questions that are coming through. Obviously, this is just sort of the first blush. It's introductory, but if people wanted to talk more, have more questions, I think this should be the first of many conversations. Don't just try to get this all in your brain here at this point. So thank you so much for everybody joining in here. So we're going to move into key places to save money. And I want to talk about specific cost containment tactics. I want you to leave here knowing that they exist. I want you to leave here knowing that you can confidently talk about them. There's a lot here, so there's definitely going to be resources after this that you can use to learn more and keep reading. So we're going to kind of introduce these topics here and talk about what they are and why they're important. And then afterwards, I'll provide resources for you to be able to dig in more on your own time and keep learning more. And then we're going to also talk about data, how to use data to show savings. I'll give some demos of ways that you can start the conversation and actually use plan data to make a financial case. Again, this is becoming a financial conversation, a supply chain conversation, less than a decision that HR has to make once a year. There's lots of money on the table. So a quick note about networks, and this is something that comes up all the time with advisors, and just something that I think is really important to lead with, is that this is not about discounts. The game is not about network discounts anymore. 5 years ago, 10 years ago, that was enough, but these plans have become such commodities. Every broker has the same access to the same discounts, right? If you are trying to also network discounts are a black box. They're based on nothing. Hospital pricing is arbitrary. It's based on nothing. The data proves that. It's not a question. I always try to say that 50% off of a made up number is still a made up number. We are trying to get away from the world where we're making decisions based on discounts that networks say they can give us from hospitals. The new transparency rules require that prices be disclosed anyway. In a couple of years, this conversation about network discounts is going to look completely different than it does today. You need to be learning this now so that in a couple of years, you're not, totally washed out. But what we are talking about today is the conversation for plan design is not about network discounts. The reason for this is because the data is showing us that 20% of claims are driving 80% of the plan cost. In order to actually improve outcomes and lower costs on the plan, we need to build plans with that in mind. We need to stop thinking of that. A BUCA plan treats every member the same. It sees everybody the same, regardless of who you are. But we know that that's not how healthcare actually gets used. A few people are major users of healthcare, and most of them are not at all. I'm one of those not at all. I don't really go to the doctor very often. Maybe I'll start one day, but most people on the plan are not the main cost drivers. We need to be able to differentiate these people, and we need to design a plan that acknowledges this rather than treating everybody the same. So when we look at how claims come in and how costs are driven in a plan, most of the claims are office visits. They are not significant cost drivers. They don't cost a lot of money. Nothing really major is happening. There's no need to get involved. All we need to do is be able to provide these members an easy way to get a doctor's appointment. That's what the network is for. The network is an easy way to get a doctor's appointment when and if you need one. And then we've got the top of our pyramid, which is a much, much smaller percentage of claims by volume, but really where the costs are being driven, which is imaging and diagnostics, which is a place where most people overpay. Huge discrepancies in the prices for imaging and diagnostics, and we'll look at some of that data in just a little bit here. And surgeries, procedures, either elective or emergent, but this is where most of the high ticket claims are coming, that and chronic illness. Surgeries and procedures like this have the largest variance in price, in quality, I'm sorry. You know, hospital to hospital, even doctor to doctor in the same practice, there's a huge difference in the quality of the procedure that somebody can expect. That data needs to be taken into account when choosing providers. And there's a huge difference in the cost. Generally, the rule of thumb in healthcare is a bit odd, but these things tend to be inversely related. Higher quality procedures tend to be less expensive than lower quality. And the reason is because most of the time, a higher quality procedure is being performed by a specialty surgery center who focus very particularly on that procedure. They've got all of the processes nailed down. They do hundreds of them a year. They've got all of the equipment purchased. They've got much lower overhead compared to, say, a general surgeon or even a specialist surgeon at a hospital who is maybe doing a few of these surgeries a month. There's huge hospital overhead costs for having these procedures done. People wind up getting a surgery that should have cost $15,000 done for $100,000. And again, we'll look at that in some of the data here in just a little bit. But when we are talking about plan design, what we're looking at here is how do we make a plan that is designed to make these top two pieces of the pyramid special, but easy for everybody else in the group to get access. And so when we look at how to design plans, again, we need to build a plan that has improved outcomes and lower costs in mind. This is not something that people are getting from fully insured BUCAs today. There are actually 12 what we call levers to pull that can change the costs and affect the outcomes in a health plan. So we're going to look at these today. We can go deep on, I wouldn't recommend we go deep on all 12 because it would take a lot of time. But again, I will be providing resources after this that you can use to learn more about this. But what we're talking about is a very specific set of tactics. Self-funded plans like this should keep in mind that we can use to control costs on the plan. So I'm going to dive into to what these are here. The first is the network, and I was just talking about this previously. There are networks that people have heard of that normal people on the street know, Blue Cross, Cigna, things like that. There are a lot of networks that, you know, most people maybe aren't familiar with the brand, but they're just as good and just as broad. And then there are networks that are very specific and designed for a really specific purpose or region or whatever. The question is, what is the right network for this group? What is the group's goals and what is the network that's going to let them hit their goal? Because a lot of times the network you affiliate your plan with comes with rules about how you're allowed to use that network. I was giving the example in the previous module. You can affiliate your plan with the Cigna network, name brand, very, very wide access. Most people wouldn't complain about it, but they're not going to let you direct contract. They're not going to let you audit bills for fraud, waste, and abuse before your hands get tied in a lot of cost payment. So depending on what the group's goals are for their plan, Cigna might be a good network option, might not be. The goal is that we need to look at all of the available options and understand what the group's trying to achieve in order to put them in the right place. And if we can't get it year one, we kind of build towards this over multiple years. And this includes, by the way, this is including direct contracting or, you know, networks of direct contracted providers. That's something that we do a lot of for the groups that we've got. The second is, you might call it tiering or intra navigation, but all it is, it's just making sure that we are using, making sure that we're being proactive about where members are getting care. Right now, most members are not equipped to shop for their healthcare. Most members are not, you know, data about quality is not available to them. You could, you know, people say like, people spend more time shopping for a TV than they do for a doctor. You spend more time qualifying what purse you're going to buy than the person who's going to be performing life-changing surgery on you. But that data is available. It's out there. We need to be using it, and we need to be helping members see that data and understand that they're able to make a decision. And so being proactive, understanding where that data lives, and then being proactive about engaging with patients. That's what TPAs do. That's what partners like Accolade and Quantum do. We can build plans that actually bring this information forward to members and don't just make them, you're on your own, good luck finding a doctor. When we do that, we steer them towards higher quality providers. We steer them towards lower cost procedures. And really it's only, a few members in the plan that really ever wind up needing something like that. But so building a plan that puts this in mind is really, really important. One that I want to talk about because it's becoming much, much more popular. You're definitely getting questions about it, or if you haven't already, you will, is direct primary care. This is blowing up in the space. Everybody, all the employers want to know about direct primary care. The concept, if anybody's not familiar with direct primary care, the concept is it kind of mirrors value-based care. You pay a subscription-based fee. You've got a primary care provider's office that limits the number of patients that they take in. And so what you're doing, instead of paying, $300 every time somebody goes to the doctor, you're paying $50 a month. That person can go whenever they want. The value there is that this person now has one single point of contact for all of their medical needs. A lot of people have, they might have 3 or 4 different doctors. Those doctors don't talk to each other. Their plan is really disjointed. They're not really getting like a whole health approach. Direct primary care is coming into this market now and saying that we can drive way better results when we give people a single quarterback for all of their care. So companies like Eden, Firefly, and Hint are growing very quickly. And a lot of groups are starting to wonder, how can we offer more direct primary care to our members? This is something that needs to be thought through and built into the plan design. And if anybody has any questions about any of these, you can feel free to shout them out or put them into the chat. Again, like I said, I want to kind of touch on some key ones here. Bundled surgery and steerage to bundled surgery is really key. And I'm actually about to give a demonstration of what I'm talking about here. But outside of the major network that a plan is using for its broad access, there are networks, smaller networks of bundled surgical options or centers of excellence where the full price of the procedure has been pre-negotiated, and that bundled surgeon or that bundled surgery center actually takes on some of the risk. So they actually guarantee we'll do this procedure right the first time, and if we don't, we're liable for the costs. So you wind up getting much better quality, and there's no incentive to keep patients overnight, to keep them coming back. A lot of hospitals, they make their money off of elective procedures. They're designed to pull that apart as much as possible. A bundled surgery can provide the exact same or better quality care for a much lower rate to the plan. The key is to be proactive with members when they have pre-certifications come up for surgery, and to engage them before they've made that decision and say, hey, we've got options for you. So I will actually, I want to kind of break out of this presentation for just a minute and show you kind of a real world example of what we're talking about here. So this is a platform called Coral. This is a bundled surgery company. They run a network of bundled surgery opportunities. They have all kinds of procedures available in their network, spaced all over the US. And so, for example, if a patient was having knee surgery, that can be a pretty costly procedure. It can be a pretty risky procedure. If something goes wrong in your knee surgery, you could be on the slab again. You could be out of work for weeks and months. It's very important to get it right the first time. And it's very, very important not to overpay for this, because a knee surgery is a pretty standard thing. You can get this anywhere. And so what a bundled surgery partner in this plan would do, like Coral, is to say, okay, we need a knee surgery and we need, it might make me log in again. Yeah, hold on just a second. So yeah, essentially searching by the procedure type. Here's knee surgeries all over the country. we'll use my zip code, which is in Atlanta, Georgia here, you can see that there's a lot of knee surgery options. You can get a knee surgery for $11,000. You can get a knee surgery for up to $30,000. The idea is that the patient should not only consider wherever they're referred by their doctor, but the plan should be prepared to help people shop and coordinate where they're going to get that care and try to find, is there a higher quality, lower price surgeon in your area that can do a better job at this than wherever you were referred? Some patients want to accept that. Some patients don't. The plan's job isn't to make patients make one decision or another, but you can build in incentives and say, if you choose to go to this bundled surgery center, which is, not where you were referred, maybe it's a little bit of a farther drive, but if you choose to go to this higher quality, lower cost center, the plan will make it worth your while. The plan will write off your deductible. The plan will cover your expenses to and from. You can create incentives in the plan design that would actually steer patients toward higher quality, lower cost care. And when you do that, the patient wins. They pay nothing out of pocket for a better surgery, and the plan wins. You wind up with a member who has had a better surgery. They're less at risk to be out of work longer, and the cost to the plan is much, much reduced. So this is a very different way of thinking about steerage and guidance for providers. Touching on a couple more of what I think are important ones, fraud, waste, and abuse. This needs to be built into this plan. That's kind of obvious. Prescription sourcing is another one. I see this all the time where, we've had a BI report, a Blues Insight report, where somebody is paying $25,000 a year for Stelara. And that's just kind of something that's really a cost driver on the plan, right? It can be huge. But there are programs that are designed specifically to help members and to help patients find opportunities to redirect their specialty drugs. And so script sourcing is a vendor here, and I'll show you kind of another demo. If you have a patient who's taking Stelara, let's find out Stelara actually has a manufacturer's assistance program available. It's also available on the international market. And so a partner like script sourcing that gets built into the plan says, okay, Mr. or Mrs. member, you are taking Stelara right now. You're paying $500 a month for it, and it's costing the plan $25,000 a month. But you can sign up for the manufacturer's assistance program, and we can guide you through that. And if you qualify for the manufacturer's assistance program, you get this drug for free. It starts to cost you nothing. And the plan gets it for a drastically reduced price, something like the plan is paying 20 cents on the dollar for it. Or internationally, we can find this exact same drug from Canada or New Zealand or Israel and have it shipped directly to you. And the cost will be far, far less to both you and the plan. And so, we can do this for Stelara. We can do this for Humira. There are major cost-driving drugs that these plans are paying hundreds of thousands of dollars for year over year that we should be taking a look and finding out how can we change where this drug is coming from in order to affect the price of this drug. So RX sourcing is a major one. Anything to do with the pharmacy. There's been a lot of reports that have come out in the last couple of weeks about America's pharmacy practices and what's going on there. It's a huge, huge place where people are overspending. So having a transparent PBM, somebody who's got a pass-through model, who's going to make sure the group gets their coupons, makes sure the group, the formulary is designed not to maximize rebates, but to reduce costs at all. If I told you, hey, I got a huge tax return this year, I would hope that you would say, well, that means you're doing your taxes wrong. The same thing is happening for these groups with their drugs. They're saying, oh, we're getting so many rebates for all of these drugs. It's great. Well, that just tells me that you're prepaying for drugs that you shouldn't be paying for in the first place. We need to be finding transparent PBM partners who can write the formularies correctly, who can make sure that coupons are getting back to the group. And we can do that all very, very simply in a self-funded arrangement. Oops. White bagging of drugs is something similar. It simply means looking elsewhere for where we're buying drugs that people are already using. We don't have to use the channels that the hospital says or that the carrier says. We have a lot of control over that in these self-funded groups, and there can be huge savings involved there. Same with all kinds of things, renal failure, air ambulances. There's lots of places in a plan year where plans overpay. You need oversight on these things. You need plan design that's designed to be watching for the $18,000 air ambulance and saying, why did you transfer them on an air ambulance? The plan's not going to pay for that, or pre-certifications for things like that we can start to steer. And similarly, mental health. Mental health is very, very big right now. It's coming up on every renewal that we are having. You're probably hearing about it. It's not a huge cost driver of plans, but it does make a really big difference in the member satisfaction. And it's something that a lot of plans want to be offering now. There are partners that this is available through Teladoc and Ginger, but a plan, in order to be comprehensive and well-rounded, should be thinking to itself, how can we incorporate mental health services into this plan design? On a fully insured or a BUCA plan, you're kind of at the mercy of whether Blue Cross decides they want to cover that this year. But when you're in a self-funded arrangement, if this is important to your company, we can build it in. If this is something you want to explore, it can be something that you choose to offer. You have a lot more control in that respect. And then finally, patient financing. I think this is something that's coming up as well, but just about lowering the barrier to people who need to be able to kind of make payments over time for certain deductibles. If you're designing your plan to waive deductibles, if people follow steerage anyway, maybe it wouldn't be a problem. But these are the 12 levers that when Flume gets involved in plan design and starts looking at, we start saying, what does the data tell us? What are the things that we can do to start addressing the costs of the plan? And it just becomes a totally different conversation than, okay, here's your 3 off-the-shelf plan designs. Now it's like, what do you want? What could this plan possibly be? It's a very different and much richer conversation. So I'll pause here. I acknowledge that was a lot of information. Does anybody have any questions about these cost containment tactics or anything like that?
Grant,
Oh, go ahead, Tom. There's another question. Yeah, ask yours and then I'll ask another one that came up.
so Grant, I'm assuming that when we would approach you, you would be guiding us or helping us pick these components. I have no experience with any of these vendors. Where do I get that knowledge?
Yeah, great question. So this was, like I said, I'm going to be providing information still pretty high level to start learning. And then B, I mentioned the organizations like the Health Rosetta, like the Masterminds. There are definitely communities that are talking about this. There are certifications for this. The next generation of brokers, the people who are, I think, going to be winners in the next 5 years as this landscape starts to shift, are the people who are learning how to talk about this now and are becoming experts at it. And so again, I'll be providing after this resources to join the conversation, find mentors, just kind of read about it, whatever is right for you. But this is definitely out there, and you can certainly start to level up your knowledge about this, and I'll provide those resources.
Great, thank you.
Yeah, it seems like a lot. I know it seems like a lot. Once it's kind of structured, and again, this is the first thing that Flume starts to think about when somebody brings a group to us, and some of the brokers have never heard of these things. And our job is to introduce the concepts and, say, hey, here's a plan design that we've already got. It's got all these pieces built in. All you have to do is pitch it to the client. And sometimes even the broker is very opinionated, and he or she wants to get in there and make changes. And so it really is just about finding the right partners.
I just want to say one thing before Karen jumps in, because I tell you what, Karen's been innovative, and this group, I'm sure that brokers have been with her a long time. We started with the HSA with that concept years ago when traditional brokers fought that, and So you get a half a loaf, but it's better than none. And that's a concept here too. You know, you might be sacrificing on the premium side as far as commissions go, because on self-funded, maybe you build in a fee that might be lower than what your typical traditional compensation would be. But we'll be the ones leading the field in the future when everybody else gets, you know, dropped
Yeah.
away. So what's your phone number to get a hold of you directly? You're going to post that on your screen?
Yes, I will.
Okay.
Yeah, absolutely.
I'll keep my mouth shut, Karen. I'm sorry.
Oh, no, you can keep talking. It's good that somebody other than me is asking questions. All right, so the other question, and there's a couple of people that sent direct questions to me about it. Well, you know, this is a pushback that I know when I'm introducing the idea of coming off of a BUCA traditional style program is always a concern with an employer. How does an employer really save? We know we're going to have the savings, but communicate to the employees how to actually use these tools. Like we don't, you know, like in a reference-based pricing, lots of times they're left on their own.
Oh, yeah.
Figure it out. So we don't want that.
Right.
We want that guidance. So, you know, when I've been trying to build these kind of programs together, we all come to you, let's say, and you say, well, these are the vendors we use. And I'll say, well, we want script sourcing or we want to use PBMRX or something like that. So we're able to tell you the experiences of that. So how does the employer communicate to the employee, or is it done through the nurse concierge service? Or
Yeah, good question. I mean, there's a lot of different ways that this is happening right now. Personally, my philosophy, Flume's philosophy is you can put all of the cost containment features you want into a plan, but if members aren't using them, they're worthless.
right.
So you can't just build the plan. You need that other side of the coin, which is about the member engagement, which is about connecting with the member. If we go back and take a look at the, I'm going to pull this up really quickly. If we go back and we take a look at the kind of pyramid of how this, how the plan works out, you can see, like I said, most people on the plan will not ever interact with or need to interact with some kind of steerage and guidance. Most of them are not going to be having major surgeries. So what you're really talking about in this case is a very small number of people relatively. If you've got 200 people on your plan, you know, maybe 20, 30 of them in a year would be candidates for some kind of steerage and guidance, probably less. That's a very, very manageable number. So one, the employer needs to be on board with communicating to employees just on a regular basis about how the plan is doing, what's available. Open enrollment is important, but also throughout the year, it needs to be part of a plan and a kind of a cultural shift. And then two, you know, the way that Flume is built is we are designed to be very proactive in reaching out to members. Our system is capable of seeing every pre-cert that comes in the door. We know when people need MRIs. We know when somebody's taking a $25,000 drug. And our job is to use that data and take proactive steps to engage with the patient and say, hey, we saw you fill this Stelara prescription. Did you know we think we can get you this drug for free? Do you want to take a look at this? And that's a real case example. And we had 100% of the members that we reached out to said, yeah, I would like this drug for free because it cost me $3,000 a year. And so Flume as a TPA takes a very proactive approach in engaging patients. Other TPAs are doing that as well. I feel like it's kind of happening more and more now, but you do need to be proactive and everybody needs to be on board about making sure that members know these programs are available to them and trying to drive up that utilization.
So if I was to incorporate all of this with a reference-based pricing plan, then all my employees would need to follow these steps and I'd be guaranteed to save on my claim dollars.
I would say yes. If you designed your plan that way, ideally, like I was saying, you would, if you were the employer in this case, ideally you would have spent the last few years walking towards reference-based pricing. Your group would be more educated than they are today about how the health system works and how to use these programs. Those are the successful groups that we've seen. But yes, you could design the plan so that people need to use the nurse line in order to get pre-qualified. You can set all those rules when you're self-funded. When you're fully insured, you can't.
But there's no, as an employee, I do not have to follow the guidelines. If I want to go to my particular hospital and use my doctor, these cost-saving measures are simply on the employer side. I'm not required to do this.
Again, it depends on the plan design. You know, it's a simple pushback, but we have groups, for example, who in year one, they were very willing to say, you know, we would like for you to stop going to this hospital. Cleveland Clinic charges 300, 800% of Medicare. We don't want you going to Cleveland Clinic. There are better surgery centers in this area. And then we've had groups that in year 2 and 3, or one particular scenario where they said, all right, we are not going to reimburse claims from Cleveland Clinic. We've spent 3 years providing alternative options to Cleveland Clinic. You know, Mr. Member, if you want to go to Cleveland Clinic, you can, but the plan is not going to cover Cleveland Clinic claims anymore. And this is an option that the plan made because it was what the plan wanted. And it was something that they rolled out to their population.
That's reference-based pricing.
They were in a reference-based pricing environment, yes. And they had a lot. That gives you like total control over that kind of stuff.
Hey, Grant, I have to speak up. In defense of Cleveland Clinic, I had my open heart surgery there. I didn't pick them. It was the hospital that had the Cleveland Clinic within the hospital.
Mm-hmm.
So while the total cost was like $375,000 for my stay, it got adjudicated down to like $165, all said and done, all in. So you can't control this stuff. It's not like when you have an emergency open heart surgery, you're going to say, oh, wait a minute. If it's Cleveland Clinic, I don't want you to do the surgery. You know, I use Cleveland Clinic, and I heard that one of the best surgical groups for these hospital procedures.
Right. I was using, I didn't want to pick on Cleveland Clinic. I was using them because they kind of came to my mind. There's definitely a difference in planned procedures and emergent procedures.
Yeah, but we're not selling staples like Coke and Pepsi versus CNC Cola here. You know, healthcare is a little bit more, at least most consumers think of it as, well, I understand the shopping about the prescription plans and this, that. When it comes to doctors, a lot of them, and especially in New York, New Jersey area, hospital for special surgery. Oh no, I got to have my surgery for my hips, for my knees. It's got to be hospital special surgery. Well, they're not in your network. And this is a battle we have. But when you deal with owners, they don't want to hear it, you know.
Right. And there, I think a self-funded plan, you know, in a self-funded arrangement, the employer does have the opportunity to choose what they cover in certain things. The employer has the ultimate say in what they'll approve and not approve. So there's, even when they set the plan design, you know, you don't want to fall outside of regulatory compliance, but you do have the option to say, okay, go to your surgery center, you know, we'll cover that. So what we are in is an environment that has a lot more options than a fully insured BUCA plan, and it has a lot more engagement. And if the plan wants to be super open about it, they can. If the plan wants to try to give incentives and say, you know, we'd really like for you to go to Methodist versus Baptist hospitals. And if you go to Methodist, we'll waive your deductible. Maybe that's attractive to you, but maybe you are super committed to your doctor. You know, the plan, the idea here is that this employer and them as their advisor should start thinking critically about what they're paying for and how they're paying for it and what they're doing to mitigate the plan costs. Because a fully insured plan pulls no levers to mitigate costs.
How often, when you have your discussions, if the group is an average age of 58, 59, that you're going to say, gee, I don't think self-funding's for them? Because when we look at that pyramid, you're talking about the core where the majority are all just going to doctors. Whereas maybe on an older average group, you're looking at more surgeries, more MRIs, more diagnostic, and it could be a drawback.
Exactly. Yeah.
Okay.
Exactly.
What do you do when it comes down to figuring out the cost of the employee contribution on a month-to-month basis? Is it going to be a floating month-to-month contribution, or does the employer pick up the additional cost when you say, hey, you got to kick in more money this month?
Yeah, that's a great question. I haven't had that much personal experience around like setting the employee contributions and things like that. It's definitely a part of the conversation. I don't know that I'm necessarily the best person to answer that, or maybe we could talk about it tomorrow when
Fine,
Kevin
fine.
is on the
I'm
call.
talking a lot. I'm sorry. It's your meeting. Go ahead.
No, you're not. I want to get you that information. I think these are all absolutely correct questions. I'm not the expert to answer that particular one.
Understood.
Yeah. And to your other point, whether people will take it or not. Yes. Again, the point is not to make everybody shift everything they're doing. The point is to think critically about how the plan is built and operates and create opportunities for savings. If we can drive utilization, and we'll talk about this tomorrow, if we can drive utilization of cost containment programs from 5% to 30% in the population, if even just 30% more people choose to follow steerage to bundled surgical options or choose to get on manufacturer's assistance programs, that's still a major effect to the bottom line of this plan cost. It has not been hugely disruptive to the plan, and there is an upside to the plan in making those changes. And as the plan matures, it can get stronger and stronger. And we've got plans that are running, again, Walmart and Amazon, the precedent is that they're making all of the decisions about their plan. We're just trying to get employers into a situation and an environment where they can start to look at this like a supply chain and make smarter decisions about where their spend is going. Because right now they're not having that opportunity. So we're at 1 o'clock. That really was the last thing. I have one more thing to say, and then we will wrap it up. And we are going to talk about this tomorrow anyway. So it's not really even that big of a deal. But tomorrow I want to talk about data. What data is required from groups in order to get stop loss quotes? What do we need to see in order to help these groups get their money in order? So we're going to talk about that more tomorrow. Summary for today: forget the discounts. We got to get out of the game of competing on network discounts, and we got to start competing on plan design and critical thinking. The 12 levers are the best way to do that. One or all of them can have major impacts on how the plan runs. And we're going to use data to demonstrate value to a prospect. So like I said, I'm going to provide some resources after this that people can use to learn more about this, including the RFP checklist. We will be back tomorrow to learn about stop loss, and then we'll dive into a couple of different funding arrangements: PEO level funding, captives, and reference-based pricing. I'm happy to stay on if anybody wants to chat more, but officially we've reached the end of today's presentation.
Well, thank you everybody for coming.
Thanks.
Yeah, these are great. I wanted to be cognizant of everybody's time and not make anybody stay longer than they needed to. Like I said, if there are questions, I'm happy to stay on and chat, or we can bring them up tomorrow. We'll be back at 11 tomorrow.
Nice job, Grant.
Cool.
Are you
Thank you.
going to be giving us the PDF or anything that I can email out to?
Yes, I will be supplying you with all of these takeaway resources, and I'm hoping you can distribute them to the
I will.
team.
I'll take care of it when you send them over.
Great. Okay. Well,
Love to engage new ideas and new thoughts.
yeah, 100%. Thank you all so much. This has been great. I will see everybody tomorrow.
Okay, you got it, Grant. Thanks again.
Bye. Thank you, Karen.
Sure thing.